All right, so let's just, it's brief, so cardiac is very intense. Once we get back to like ICU, that's where you're gonna have to start understanding like the different types of like intra-aortic balloon pumps, the Swan-Ganz, all those type of things. But for right now, this is just your intro. So let's just let's focus on that. So what are the, big question here, what are the three layers of your heart?
Endo, myo, and peri.
Also epi.
Oh, yeah.
Epi. And then how many chambers do you have?
Four.
Okay, what are they?
Right atrium, left atrium.
Yeah. What's the pacemaker of your heart?
SA node,
If the SA node stops working, what does it go to?
AV node,
Okay. So it goes SA to AV, AV to,
Purkinje fibers,
Purkinje fibers.
then,
Bundle of this?
so remember it goes SA, AV, bundle of His, then Purkinje.
Okay.
Purkin.
So when we think about it in like the long run of everything, or if you think of, let's just talk about your conduction system. Think of it like an electrical wiring in a house, right? Your heart is the house. The heart has its own built-in electrical system to tell when it's to contract. So we start SA, and then that's located where? Yes, right atrium. So then that's where everything's going to start, right? And the SA node is also known as the pacemaker of the heart, the natural pacemaker of the heart. So the electrical impulses then travel through the atria, which cause their contraction. It pauses a little bit briefly at the AV node, because it'll allow, so why is the pause important? Let me ask you guys this. I try to ask you more questions than tell you.
Is it a hard time to fill the heart?
Yeah, refill.
There you go. Yes, the pause is very important as soon as it comes in because that pause allows for what part of your heart to fill? Yes, and then it will pump out. So the impulse then travels through the bundle of His, bundle branches, Purkinje fibers, and then that's where we get our ventricular contraction. So let's give just a clinical question here. Let's say you see a patient and they suddenly develop a heart rate of 35 BPM and dizziness. Let's say you get an EKG. Oh, it shows that the SA node is not functioning properly. What do you think is happening inside the heart?
Dysrhythmia.
The AV node is taking over because the AV node is not your SA node, so it's not supposed to work as, hard as your SA. So it is a little bit slower. That's why the heart rate's slower. That's why they might be starting to feel dizziness. Their heart's not used to this. The AV is kind of like our backup pacemaker. And it fires about 40 to 60 beats per minute, but that's not enough, right? A normal heart rate is
60 to 100.
Well, technically, right, I think I read something different in the book, right? Isn't it like 50 to 100? We know it at 60 to 100 though in class.
just keep it 60 to 100.
Okay, cool.
I mean,
Stop confusing us.
I'm just saying I read it yesterday. I was like, hey, that's not what they taught us.
I know, the books, so the thing with like your textbooks and stuff like that, they are always changing, but through the American College of Cardiology, it still should say 60. Is like the 60 to 100-ish. Now when it comes to blood pressure, that's a whole different thing, but we'll get to that soon. So let's see, let's go through some of these other things. So let's talk about your cardiac cycle. So the cardiac cycle refers to the events that occur in the heart from the beginning of one heartbeat to your next, right? So each cycle has three major sequential events. We have atrial systole, ventricular systole, and then diastole. So this is a big thing here, is your cardiac action potential. So this is kind of where there's repolarization, final repolarization, resting. So depolarization first, that's the electrical activation of the cell caused by influx of sodium into the cell while potassium exits it. Repolarization is the return of the cell to resting state, which is by a re-entry of potassium, and then you have refractory periods. Those are always fun. That's just, oh God. Fun stuff. But then we're gonna talk about what I like more, which is the structure and function of your actual system, which is like your EKG. So so we'll talk about normal sinus, what a P wave is, QRS, T wave, all that fun stuff. So when it comes to it, when you're reading an EKG, try to think simple. So your P wave means atrial depolarization. QRS is ventricular depolarization. T wave is that repolarization phase. So how I would say to memorize it, a little note I made for myself here. Depolarization equals contraction, repolarization equals recovery. I tried taking notes from my old nursing textbooks that I had and like notebooks because for some reason I still kept them. Don't do that, burn them afterwards. I should have done that. I did that with my scrubs.
Not the books, but the scrubs, yeah.
Yeah, you think I wanted to see those things again? No?
What did you say? I'm sorry, it was depolarization.
Yeah, so depolarization equals contraction, repolarization equals recovery. So like, let's do an example. Mr. Smith arrives complaining of palpitations. His EKG shows no visible P waves and more of an irregular rhythm, which may indicate, we'll say, AFib, because we're gonna have to talk about that sooner or later. So, why do you think AFib is so dangerous? And what do you think is a huge complication about that we may worry about?
Because you're not allowed, the heart's not allowed enough time to relax.
Yeah, right, because so your normal heart is love dub, right? Love dub. Well, in AFib, this is your atrium. Just freaking the hell out. Just freaking out. What do you think is a big thing though that can happen? Like, just, you can shot in the dark it, it's totally fine. You're here to learn, right? What do you think is a huge complication or a risk that may happen to these patients that have AFib?
Hypoxemia.
So yeah, they can have low perfusion, they can start having more like dizziness, lightheadedness, but what's a life-threatening risk?
Cardiac arrest.
So sometimes AFib can go into other things, but a big one, the one that we really worry about, stroke. So I want you to think about it this way. This is freaking out a lot, right? But your ventricle is still trying to pump normally. What happens is your blood's pooling more. What happens when your blood pools? It will clot, and then what happens if you
Shoots the clot to the brain.
next thing you know, you get stroke, and you have DVT. These are life-threatening. That's why with patients who have AFib, what do you think we give them medication-wise?
Blood thinners.
Blood thinners.
Warfarin, Coumadin.
Yep. So they will be put on like dual most of the time, which is like they could be put on Eliquis and aspirin just to make sure, or they could put on, you know, but they have a couple. But the main one I've always seen in my work is always like Plavix and
Isn't it like aspirin and I don't know the name, but like clopidogrel? It's a
clopidogrel.
Yeah.
So that's called DOAC, which is like double anticoagulant. So with that, that's what you give them, right? Now there's other medications that we give later, but you'll learn that across the hall in critical care when we start talking about like more what we can give them, or what other things that can be done. Because with AFib, there's a lot more. What is this? No, I don't care. They send me emails and I just, because I have a very case manager brain, so the minute I hear an email thing, I'm like, oh crap, I gotta go check. So that's something just to kind of so do you guys understand kind of like that? Like, so if you're not able to depolarize correctly, and you go into something like AFib where the P wave isn't showing, right? It's gonna have to be a bad time. You're gonna freak out. It's gonna suck. Mainly for your patient and you, because then when you look at the monitor, you go, oh damn, here we go again.
One of those days.
So, let's see if I can try to, I have one thing here that I have for you guys, maybe this will, so. And then, I'll do that one last. So, how I try to remember it, oh, I hate being a left-handed person. So, if it helps you remember, think of P prime to ventricles. QRS is quick.
Quick.
Think of quick ventricular response. Q. There's an S here. Just think of it with a Q. Or I would say either response or I say do this one instead. Try squeeze. So try to think of QRS. And then T, we have your T wave, which equals time to recover. If it helps. Like a little memory trick of how to remember it. So P wave, it's priming the ventricles, right? QRS, quick ventricular squeeze, T, recover. So, next on our list of fun things, coronary arteries, love them. Let's talk about your cardiac output. So this is where a lot of like what I take care of in patients is. So a big thing here is your ejection fraction. So this is the percentage of end diastolic volume that's ejected from the heart. So in a normal, a normal adult, let's see. So a normal EF in an adult, can anyone like ballpark where you think it might be? Where do you think it is? It's in a percentage. So there's percentages. What do you think is a normal adult's EF?
60.
Yeah, 60 to about 70, possibly. That's normal. That's where any of us should be right now. Right now. Now, there is, when we get to it, heart failure, there is reduced ejection fraction and preserved ejection fraction. Reduced means this goes down. Preserved means this can be the same, but they just have a lot more fluid issues. Those are the patients I don't like the most. Because with reduced ejection fraction, you can bump it back up. You can bring a patient down from, I've had as low as 5%, go back up to about 40, 50, and live a normal life. Fun fact too, when you get started on medications, when we get to that, these are just little like things that will just spark off in my brain. Within 3 days of getting started on what's called GDMT, which is guideline directed medical therapy, you can see an increase in their ejection fraction, like right away, after about 3 days of just being on the meds. If they take them. Some people don't. Or one guy once said, the squirrels took them, and I was like, damn, that's a lot of dead squirrels on a beta blocker right now. So cardiac output. So cardiac output is our stroke volume, and it is stroke volume times heart rate. So a normal cardiac output is about 4 to 8 liters a minute. Stroke volume, when we talk about it, is the amount of blood that's ejected with each heartbeat. So you have first what's called the preload, a degree of stretch of the cardiac muscle fibers at the end of diastole. You have afterload, which is resistance of ejection of blood from the ventricle. And then contractility, the ability of cardiac muscle to shorten in response to electrical impulse. And then let me go to my note page. So I want you to think about it like this. If heart rate's too slow, what does that mean for our output? Decrease. If heart rate's too fast, what do you think's happening there though?
Overworking.
So if it's too slow, we're not pumping out a lot, right? But if it's too fast, we're also not pumping out a lot because you're not filling, right? If not enough is being filled and being pumped out, you're still having low cardiac output. Either can lead to like poor perfusion of a patient. That's why we try to keep them balanced, normal. So if a patient with sepsis has a heart rate of about 150, usually a lot of people think fast heart rate means more cardiac output. But at high rates, the ventricles don't have really enough time to fill. Because you want to think about it 150 times a minute, that's just going off, right? I mean, we drink things like this and we increase our, our heart rate and everything all the time. Still gonna drink. God bless. But here's a fun fact for you guys. So in some situations, when you take care of people in the future, depending on where you work, there can be instances where people may have really low heart rates, but they're completely perfused fine. what type of patients do you think that would be? Yeah, it would definitely be athletes because some of them live in the 40s. I had one guy living in the 30s. It was like the first patient I ever took care of. I was like an extern in like a research department, and this guy came in for a testosterone study, and I just remember doing his like getting his heart rate and everything, and I was like 35. And like the nurse is right next to me, and she's just like, "What do you think it is?" I'm like, "I don't know, boss. I'm scared. I don't want to hit that code blue button." But he was a professional runner, and he would do marathons like once a month, just going for it. And I was like, "Oh God, okay." So just think about it that way. So just kind of keep that in mind as like a little like, okay, if I have a guy that's like an athlete that's, you know, coming in, or if I see someone that's coming in and they're a completely normal person and they're just sitting there like this, just being like, what's up? Oh, my heart rate? Yeah, that's fine. Oh, it's 40? Yeah, that's cool. First question to ask him, do you work out a lot? Do you do a lot of exercise? It may sound stupid, but it could help answer it, because sometimes, I tell you this now, there will be doctors that you'll meet that are dumber than a box of rocks. Like they're very book smart, like they're very smart, they're doctors, but they're street smart wise. They are very, like, they won't piece together things. That's why nurses are there. Like, we can ask them questions that maybe we get answers to, right? Because they'll look at it and be like, oh, they're bradycardic. Well, that's where you come in and maybe you're just like, oh yeah, I talked to the guy. He's an athlete and he does this, 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 and this. Doctor may not have gotten that during their assessment. That's why you're there. You help fill in those last little pieces that need to be there. Because sometimes it gets worse. So that's kind of just a little tidbit on your cardiac output and stroke volume. So just know that cardiac output is stroke volume times your heart rate. I don't think I gave you guys any questions on that. You guys don't really get more of that until about critical care, because that's where you're going to start really, I know that's like almost a year from now, but I want you guys prepared for it. I want you guys to critically think at that level, because I want you guys to go in there. I want you to show up and be like, yeah, we already know this. And then I'll stand from across the hall and be like, those are my babies. They did it. So let's start your assessment of your cardiovascular system. Pretty easy. You get health history, you get demographics, you get family and genetic history. Those are all major questions, right? Big thing here is like family, genetic, like yes, you need to ask this because there could be a family history of, you know, maybe they have really bad heart health, right? Maybe their mom, their dad, and their grandparents, or even before that, or maybe it's just all maternal side, all have a history of cardiovascular disease. That puts them at risk for it. So if you know that you're at risk for something like that, and this is my life lesson to all of you, because I've had a lot of young people now. Like, I'm used to geriatric people, right? I'm used to like vets, Vietnam vets that are coming in, and now it's filtering out more to Korean War vets and everything like that are like, they're old, they have heart problems because of a lot of other issues, right? I'm now getting like 20 and 30-year-olds that are coming in, getting like cardiac CTs, getting all these things, getting done to them heart-wise now, because they have a family history and they're not taking care of themselves right away, and things are just starting to happen. There also could be like hypertension. Untreated hypertension can lead to heart failure because you're overworking your heart. So if you have high blood pressure now, or if you think that maybe you have a family history of maybe some heart issues, maybe you should go see your doctor. I don't know any in the area. I'll be honest, I really don't know anyone in this area. I've lived here for like 4 years and I don't leave the house. It's not a joke, it's true.
No judgment.
Respect. But okay, so common symptoms or discomfort that people can say that they feel with cardiovascular, like your assessment. I have a lot of chest pain. Yeah, angina, that's a big thing. They can say that they have pain or discomfort in other areas of the upper body. They can have shortness of breath, or also known as dyspnea. They can have peripheral edema, so they can have weight gain, abdominal distension. Those are all big things to look for, especially in your heart failure patients. peripheral edema, abdominal distension, weight gain. Those are all big things that they can have. I've had guys that you know what, great story to tell you right now. I'm dealing with, if any of you ever go into case management, we'll meet for a drink and a smoke after, because dealing with skilled nursing facilities from my end, like down there, awful. Like you could give them everything under the sun order wise, and they just don't, like the nurses for some reason aren't putting it together that, oh, he gained 3 pounds overnight, we should diurese him more. I had a guy, I gained 30 pounds of just pure fluid. Like his arms were tripled in size, like very bad, like I had to send him to ER. And then they were like arguing with me, they're like, well, who's gonna accept him for a direct admit? I'm like, no, he's going to ER, we're not admitting him. He's gonna go in there first, because they need to see him. Because I said a lot of other choice words that I couldn't say in front of you all because you're students and I'm trying to be nice-ish. Other things people can feel, palpitations or fatigue, dizziness, syncope. So those are things that can maybe happen because of things like AFib, right? Or low cardiac output. They can start feeling a little bit more dizzy, lightheaded. So those are things. A big thing here is what you consider your modifiable versus non-modifiable risk factors. So what do you think is modifiable?
Something they can change.
And what can that be? What would you tell me as a patient? What could I modify?
Stop smoking, stop drinking, exercise,
Mhm.
more water,
Yeah?
low
Those are-
electrolytes.
That's pretty, yeah, low stress, okay. Yes, stress, your diet, your exercise, your drinking, smoking. Really a big one is diet. Low sodium. There's so much salt in everything, like just cut it back. And then there's non-modifiable. So like your family history, those genetics, things that like you're at a predisposition for, you can't really change it. Can you stop a lot of things? Yeah. Can you cut it off before it starts?
Yeah.
A little bit, yes. You can start like, oh, my mom, my dad, or like my entire, let's say my paternal side, all have hypertension. I know that I'm at risk for maybe, maybe I have higher blood pressure. Maybe it's just genetic that we all have it, right? I'm gonna start going to the doctor, we're gonna just check me out, we're just gonna see where I'm at, we'll go from there. Oh, I have a family history of cardiovascular disease. That means that maybe we have, higher like lipids. Maybe we have, maybe I need to be starting putting on cholesterol meds a little bit earlier, just to stop the process. Just things like that. You just want your patients to know like what's modifiable, what's not modifiable, because they're just like, if I could go back and change things, well, you can't now, but we can start working on what can be done, right? Or so on. So let's talk about what we got next. We have some fun stuff. So physical history, general appearance of your patient, their skin and extremities, their blood pressure. Does anyone know how to take an orthostatic blood pressure?
Yes.
Okay, tell me how.
Laying down, sitting, standing.
How long are you waiting in between?
3 minutes.
2 to 3 minutes.
Perfect. So proud of you guys. So heart inspect, palpate, auscultate, assessment of their other systems. You want to check what medications they could be on, their nutrition, sodium. Elimination, that's kind of more on our heart failure aspect, right? Like we want to make sure they're peeing. Because if they're not peeing, where's that fluid going?
Into
their extremities.
Coming back into them, right? Their activity, their exercise, their sleep, coping, stress. Nursing students, you guys have a lot of stress. Remember to calm down. Take a breath. Have a Kit Kat. Have a break, have a Kit Kat, So we'll talk about a little bit of these, your lab tests, a little bit as we progress throughout the rest of this, but big ones here, your blood chemistry. So have you guys already, for me to gauge out there, how much do you guys know already about like your lab tests and like?
Nothing at all.
No.
Okay, we're gonna.
He went from proud to disheveled.
No, I always look disheveled, don't get me wrong. Okay. Give me a second, and then I'm gonna start working on something for you guys too, because I only go through so much of this stuff. I want you guys to know your labs ahead of time. So that way you're at least a little bit ahead. Alright. Because those will be important. Because this is actually very important because a part of your NCLEX is going to be where, give me 1 second here, no, that's white blood cells. Let's do your serum electrolytes. There we go. Okay. So a big thing here on the NCLEX is your labs. So we're gonna take a little detour real fast. So this is just for you guys to just kind of remember. I have to send my regards to the nice TikTok lady that got me all these stupid markers. So let's talk about a couple of them. So major ones. Let's see, what else do you want? You guys have good, yeah. What else do we have? Chloride, phosphorus. Phosphorus, what else do we have? I'll write them all down all together. I mean, that's awesome. That yet. Ish. Alright, so big one here, sodium, normal in an adult, 135 to 145. Potassium, a little bit different nowadays-ish. Remember, these are subject to change. Always do what's in your Kaplan for this one. Follow Kaplan's one, because that's what your guys' exams are going to be on, alright? So if it says like 4.5, follow Kaplan. This is just from me. Like, this is what I was taught, and this is what I get in a lot of hospitals. That's kind of the range you have, but now they're changing that too to where it's kind of always being different, okay? So I just want you guys to know that, okay? Yeah, that's one. And then chloride is 95 to 105. Then your phosphorus is 34.5.
Is calcium one we do or no?
Calcium's on there, but it's not really a part of your electrolyte panel for a lot of them. Let's see. Another one here. So your normal creatinine is 0.7 to 1.3. That varies as well. That varies a lot. 10 to 20 for your bun. Then there's calcium. So this one. So it can either go 9 to 10.5. This is milligrams.
What's CR?
Creatinine. That's a liter. Or it goes 4.5 to 5.2, and that's MEQs. So that's kind of basic stuff.
Can I take a picture of that real quick? Sorry. Thank you.
Please follow what's in Kaplan,
Yes.
though. Because everything depends. But this is where it will matter a lot is like in your NCLEX. Like that's just gonna pop up on there. You're gonna have tests that are just gonna run that tell you like these are your patient's lab values. You should know how to interpret them. So this is just kind of I know I'm kind of like everywhere for it, but now that I know that you guys haven't had that yet, I kind of want you guys to start having it just to make sure, you know.
So for calcium, it's the bottom two?
Yeah, it can be either or, it depends. So it's either it goes milligram per deciliter or it's MEQs. So it depends on where you're at, but that's...
Oh, I'll put a star next to that one.
Most follow that, but hey, you never know. sometimes things happen where you're just like, oh, okay. Let's see. Maybe I can pull up something here. And then a couple other things. I'm just gonna take a picture of some of these ones real quick. Bless you.
Thank you.
Alright, let's pull these over here. Alright. This will become important later, but important to have now. Alright. 14, so it's 18. 12 to 16. Alright, here's a few things as well. Hemoglobin, hematocrit, red blood cells, white blood cells. So it is different in males and females. Okay? So males 14 to 18 for hemoglobin, females 12 to 16, males 42 to 42 to 52, 37 to 47 in females, and then regular white red blood cell, but white blood cell is pretty much the same. So I just want you guys to have that, just keep it for now. We can get back into more of that stuff later, because we also are going into hematology, so we will touch base on like blood. But I just want you guys to have some of it for now. Oh Lord. I can also do your platelets. I can do your platelets PT-INR. Hold on. That way you guys have this too. Yeah, we'll go here. Platelets. Let that all out. There we go. So I put PT and PTT on there. PT is for what medication do you think? PT is for Coumadin, PTT is for heparin. And then there's specific things for each one for PT and PTT, but there's a specific calculation. We will get into that later. But this is just basics. Okay, so just basic. I just want you guys to start doing that. Follow what's in Kaplan. What I would definitely suggest if I were any of you is make flashcards where you put the lab value and then on the back tell yourself what the normal is. Like these are just like little helpful hints from me because that's how I did it when I was in nursing school. I would write everything down on flashcards, also to make it cheaper too because I mean, come on, nursing students, it sucks with this economy. If you get a thing of flashcards, cut them in half. Then you get double the amount. Just write really small. That's what I did. That's how I got through it. So we'll talk about blood chemistry and everything like that. So a big one here when it comes to cardiac, your biggest one, your potassium. Your potassium, what do you think happens if it's too low or too high?
It affects the heart.
Not enough,
What do you think happens to the heart?
not contractility.
Yeah, the contractility.
It can freeze.
Increases, right?
So it can cause arrhythmias, which can then spurt off into other arrhythmias and be life-threatening. We can start getting someone into VFib because of it. Or they can have cardiac arrest. It's great. The highest I've ever seen from someone that was alive, I have to put a star on that one because it's a little bit different. From someone that was alive and we were able to get to the ER where we could get it out of their system fast enough was about 7.9, almost 8. And then for dead, not dead on arrival, but just constantly in cardiac arrest and us trying to resuscitate. When labs finally came in, it was like an 11. And I was like, oh yeah, she's chilling with Jesus at this point. So we have that. So the a B type, I just call it BNP for short because that is what it is, BNP. That's a lab that can tell you for heart failure patients about like fluid overload. There is a specific one now that is being implemented. This is not going to be tested. This is just for you to have in the real world, depending where you go and like with clinical rotations. It's called NT-proBNP. So there's a difference with a regular BNP. It goes maybe hundreds up to a couple thousand. And the regular in my hospital is like 100 or less, means no issue. Heart failure patients can live above 100. It's just kind of like where you find their baseline at. You're like, oh, you live like in the 400s, and then if we get a lab test and you're up at like 800, we know that you might be overloaded, right? With NT-proBNP, goes into like the tens of thousands. And I just look at it sometimes and go, I don't know how to interpret this. I'm just a girl. So we could talk about those a little bit. We'll go into labs more in detail as we continue, so that way you guys can have it. Maybe I'll try to make like a lab handout for you guys. No promises. I try to work from home after I work from home. So, so we have, you guys know how to put on a 12-lead EKG, right?
Absolutely.
No.
Absolutely not.
You wanna show us?
Nearby gas station, how much pack of Newports? Who am I kidding? I'm a Camel guy. Okay, 12 leads. I think you guys have lab here, right?
Yeah.
Okay, see, I think you guys are gonna start learning this. I mean, it's day one.
Yeah.
It's nothing to worry about. I know Kristen's gonna be with you, so she'll be teaching you that. Oh my God, who is? I don't care. Sorry, I got an update. When you decide to live in a house and you update all your shit, we updated like our ADT and everything and got like more cameras and stuff like that. But it's such like a far sensor. Like the camera could be all the way up there and it will tell you like in the lab that someone's moved. I'm like, I don't care if there was a cat across the street. Just tell me if someone's breaking in.
You can adjust the radius.
I'm too lazy. I just want to read. So, okay, a 12-lead EKG. All right, let's see if I can. Okay, well, this will be fun to try to pinpoint. Okay, so we have an image on there of where it is, right? So where V1 up to V6 is. So, all right, how to put in, or not put in, but put on an EKG on a person. I would say that I'm a good example because I'm still thin enough compared to where I was when I first started nursing school. They always used me like I was a damn skeleton in there. No, I used to be really bad. Not an issue, promise. Promise, we're good. Just really fast genetics from my mother. So where you're gonna feel is you're gonna find, you're gonna go here. I mean, it's just easy because I can just find it easy. So you go up to the fourth intercostal space. You'll find the in-between V1, opposites V2. And then go mid-clavicular, right down to the nipple line is always where I go for V4, and then I put V3 in the middle, and then V6 is literally right here on the side, and V5 goes in between. That's how I do it, but that's just me. And so, remember, it's one's over here on the patient's right, so your left, and then everything else is across here. And then there is a lead here, leads on both legs. And then that's your 12 lead. Now there can be some issues that happen with that. In a hospital setting, we don't use 12 leads unless we really have to. We mainly, if they're on telemetry, like a telefloor, that's where they just get white on right, smoke over fire. That's the 3 lead. That will just be on tele for them. Or they might have a 4 or a 5. I know in Kern, I think they have a 5 lead tele, because I also teach at BC, and so I take them to Kern sometimes. Almost got into it with the respiratory therapist. They will catch me in the parking lot. But so that's where you'll have a patient. So most of the time, so here's the thing, if you have like a female patient and it's a 12 lead EKG, you gotta make sure bra doesn't have like wire in it, okay? No wire bras, because that can cause what's called an artifact. Because that's gonna just make it a little bit awkward, because it will show it, like, let's say you get it and you're just like, oh my God, she's having an active heart attack. No, it was just her bra, sweetie. They used to send me in all the time too. I was like, guys, please, why is it me? I was the only nurse available, always. So just kind of keep that in mind. So when you're doing a 12 lead on a patient, this could be like outpatient or maybe ER, or because sometimes in the ER they will want like a 12 lead on them. Because you know, if you come in and you're just like, I'm having active chest pain, we're gonna stay still. You need to tell them to stay still. You need to tell them to remain quiet. No talking to them. Don't do anything that could cause them to move or anything like that, because any little thing can make a change, and that you'll have to redo it. The systems have gotten better nowadays, where like the EKG like reading machines are a lot better, where like they'll be faster. Sometimes you have to just sit there and just wait while it took forever to read, and then it was like, no, there's a movement. And you're like, sorry, Mima, you know? So there's that. There's also like, so there are people that can wear like, and so this talks about ambulatory monitoring. Ambulatory monitoring, in my like experience in cardio, is you can wear a couple of things. There's a Holter monitor. Has anyone ever worn one before? Okay, just me, great. So when I had one back in the dinosaur ages of medicine, it actually used to be where you had to have them stickers on your chest, and you had to have a little machine with you that read it. Nowadays, it's just one singular sticker right here on the chest, and it will read you for 14 days. Then it goes and gets sent out to a third-party company. They make a nice little report about it, and then they send it to the doctors, who then go, you're fine. So there's changes in that. So that's just a tidbit, I guess. But that's kind of like ambulatory monitoring, okay? So when it's an actual 12 lead, they are hardwired into it, like you have to wire them. So you put the stickers on first, and then you connect them. If you have a patient, have a male patient, really hairy chest, what do you think you do?
Shave.
Yeah, that's pretty much
Wax
what you
them.
gotta do. Well, you do it. The first time I ever worked at a place, my research place, we like testosterone testing on men. So we had this one guy come in, not the runner, it was a different guy. Had a lot of different guys. And this guy was like full hairy chest, and the nurse I was with, who was like showing me everything, it was like my first day, and she's like putting the stuff on him, but she put extra tape on top instead of just shaving him, and then she just ripped it all off, and I just saw that single tear run down that man's face, and I went, I'm so sorry.
Poor guys.
You really went ham with that.
She needed
She
that.
had some anger.
She needed that.
I'm sure he was bleeding.
She was wrong, but, you know. Okay, so then let's talk about cardiac stress testing. So we have what's called an exercise stress test. So this is where a patient could be on a treadmill, and there's like intensity, so it progresses. So it will go up, and then they'll have an EKG on them during that time. Vital signs, symptoms are monitored. Once they achieve a target heart rate, like they're gonna have them walk or run on this treadmill until they hit the target heart rate, and then that's where they're done. Then we have pharmacological stress testing. That's called dobutamine stress testing. So dobutamine stress testing is the exact same as a regular exercise stress test, except let's say you have a double amputee. Well, they can't. I mean, it'd be really funny if they got on the treadmill, but come on. We're not dicks, guys. So a dobutamine stress test is really easy. You lay them down, they have an IV, they have an EKG on the whole time, and you're gonna give them dobutamine. And that's going to artificially increase their heart rate like they are under exercise. And the machine that's attached to them is going to have a specific heart rate level that they're going to be at. Here are some testing tips, not for your actual test, but for exercise stress test or cardiac stress test. Remember, this is my background. I have to tell people this all the time. You gotta tell them no goddamn caffeine, no chocolate, no energy drinks before, because you don't want to have their heart rate artificially increase before they come in, because the machines will try to think that it needs to be higher. And then you're gonna put too much stress on them, right? So you have to be very if let's say you work in ER. Did anyone in here want to work in ER? Beautiful. Let's say you have let's say they're you should follow up with cardiac outpatient. Even if it's just the one time you have that memory where it finally hits where you're you know what? Yeah, you're right. I do remember this. You could tell them, hey, before you go in for this, just remember, just cut down on the caffeine beforehand. At least 12 hours of holding. Also, there's another test too that you need to cut down on it, which is cardiac CT scans. Because they will be giving you certain meds like nitro and stuff like that to slow down your heart rate. Because why do you think we want a heart rate that's slow during a CT?
Easier to read?
Yes, it's easier to image. You put in some contrast. Do you want the heart rate beating like crazy during it when it's trying to capture an image? No, we want to slow it down, right? We want to capture that part of the heart and the vasculature. So that's also the same thing. You tell them you can't have caffeine, and then you get yelled at on the phone for 15 minutes where they're just well, I have coffee every day, and you're just well, I will see you in the obituary.
Not tomorrow, you won't.
So next diagnostic testing, we have radionucleotide imaging. So this is kind of like myocardial perfusion imaging. So it tests the ventricular function and wall motion. So it's just a CT. And then we also have MRI. So cardiac MRIs are very intense, the patient has to lay there for a while. CTs are easier, they're done within an hour or less. Stress tests, depending on how long it takes, can take anywhere between 2 to 4 hours. So just kind of tidbits of just advice for the future, just to know. Because if a patient's just how long do you think it will take? Just always say a couple hours.
So most commonly, we're going to see more of the pharmacologic aspect, right? Instead of putting them on a treadmill.
In outpatient, it goes more treadmill unless they need to stress test them when they're in the hospital. Then it depends on what they want to do, because it's based on cardiology at that point. If they get consulted, they could be oh, we need to stress test them, and it's well, if this guy's in here and he can walk and he's a walkie-talkie and he had chest pain, we could put him on a treadmill. They could, if they have a stress test in building. Everything I have to talk about, this is all preface. I'm sorry, I have to say this beforehand. Where I come from at the VA, we have everything at the hospital already. We're inpatient and outpatient put together. So we have everything there. We have our stress labs so people can come on down. The echo techs are easy to reach. We have everything there for them. It's meant to be a one-stop shop. In regular places like Memorial or anywhere like that, it kind of depends. But they could also, the easiest thing too is they could always just do imaging on them. I mean, it depends on what they want. I mean, if someone really does come in and they have if they're having an active heart attack, they might need to just go to cath lab at that point, or they might just need to be cathed for just because they might have an occlusion. So it all just depends. It's case by case. It's kind of whatever the doctor feels at that point.
So you're saying we can't make them do jumping jacks?
I mean, we're good if you want to, if you feel No. Do it to them, whoever works in peds, make them do jumping jacks. Especially if the parent comes in and is oh, God, they're just so full of energy. I have an idea. So echocardiogram. So this is the ultrasound of your heart. This is where you can, oh, I erased it. Your ejection fraction. That's where you get it from, is from an echo. You can also get it from cath procedures. So echo can work in two ways. There's transthoracic and transesophageal. Transthoracic means what? So it means through chest, right? So we're doing we got this, it's our probe, chest, doing it here. Transesophageal, this is a patient has to be put under anesthesia because they are gonna be asleep. So have you guys ever witnessed an endoscopy or anything like that before?
I've gone.
You had one, yeah.
Yeah. I've had
Okay,
one.
so you've had one, you know how they have to put you under for it, kind of numb your throat? That's what they're doing for this. So they have to be put under anesthesia for the probe to be put down the esophagus, and that's where you get a really, really good ultrasound image because it's right, that's the closest you can get to the heart, is right through there. And that's where the ultrasounding get like a really good image of the heart as best as they can. So it can tell you the size, the shape, and the motion of the cardiac structures. You can get results. Again, I have to preface this. At the VA, we get results like same day for a lot of our stuff. Like our staff is inpatient and outpatient, and like with me, I yell at doctors. I'm not proud of it. I keep yelling at them.
He has.
They deserve it,
I like him.
especially the fellows. Oh yeah, also Justin's tip, never go to the hospital in between June and July, because that's when all the new residents are in. Nothing against them, I have a bias.
Oh, so we're screwed because we're literally starting clinicals.
Well, you get, so it's not bad, it's just, you get like a first year who comes in, who's just graduated med school, comes in, brand new, fresh, but they're not the only ones that are taking care of you. They have an attending, they have a senior resident, but it's like, you know, they're a little bit slower, and they're just like, well, maybe we could run this test. Speak up! Just things to keep in mind. I just bully them, it's funny. I used to bully them at Children's Hospital LA all the time. I had a guy that always wore a bow tie, and that's all I called him, was bow tie. I hope he's doing well. He wanted to do dermatology, he seemed like he belonged there. So cardiac caths, so this is invasive. It's used to diagnose structural and functional disease of your heart and the great vessels of it. So a right heart cath, that's where pulmonary artery pressure and oxygen sats can be obtained, and a biopsy of the tissue can be obtained. And then your left heart cath involves more use of contrast agents. So fun fact, in a right heart cath, you can actually have a device implanted in there to monitor your pulmonary artery pressure, and it is called a CardioMEMS. And a CardioMEMS is yay big. It looks like a little butterfly, kind of. It literally is like this. It is this, and then it's just like two little wires right here. Goes right into your pulmonary artery, and then you get a special giant pillow. It's not comfortable. That you lay on, and it transmits data to tell, we'll say, it will transmit you data of me. Like I could be doing this at home, and you could be, you know, halfway up the state, and you could get the reading. Where it will then say, let's say my normal, like normals are kind of low, heart failure, it depends. I have to be very specific because sometimes you'll have guys that are like 22 to 28 is like their normal. So let's say mine is 7 to 12 and you see I'm at 16. You could call me at home and say, hey buddy, you swelling up? Yeah, it was Thanksgiving, I had a lot of salt. Really? Couldn't tell. Take your Lasix. So that's what a CardioMEMS is. So that's used with a right heart cath. So patients go under, they get a right heart cath, it gets implanted in there, and then that's where they can get that done. And then you can get a hemodynamic monitoring, so you get your central venous pressures, your pulmonary artery pressure, the IABP monitoring, that's an intra-arterial balloon pump monitoring. There's also, with it can be minimally invasive, like monitoring devices are put in. It kind of depends. I mean, so if you look at the PowerPoint slide 22, you can kind of see where some of these things are. So you can see where there is the pulmonary artery where everything is kind of put in. Let me see, I might have some other pictures. I'll try to get you guys some handouts on it. But see, with this, it's more critical care. So it's kind of like, you're learning it now, you'll get into real in-depth over there. I just point over there because that's where they're at right now. I don't know where you guys are gonna go. Maybe you'll stay in here the whole time. I wish I did when I was in nursing school. I moved all around the building. All right, coronary atherosclerosia. So this is atherosclerosis, which is an accumulation of lipid deposits and fibrous tissue within your arterial walls and the lumen. So in this, blockages and narrowing reduces your blood flow to the myocardium. And then cardiovascular disease is the leading cause of death in the US for men and women of all racial and ethnic groups. Coronary artery disease, also known as CAD, is the most prevalent right now in adults. Manifestations, they can have symptoms that are caused by the myocardial ischemia, so they can like shortness of breath, feeling more fatigued, tired, chest pain. So the most common is angina pectoris, so that is just chest pain. Other symptoms, they can have epigastric distress, so maybe like they feel like it's like heartburn a little bit. They can have pain that radiates to the jaw or the left arm, shortness of breath. So in women, if it's more, so women's like cardiac symptoms are a little bit more different than men. I mean, that's been, you know, we've been blasting that around social media now, which I will say, thank you social media to show some of that to people, but yes. So sometimes you can have a woman that comes in, she's just like, oh, I just feel like I have, like my stomach really hurts, or I feel like I have a little heartburn. Never just think, oh, it's just heartburn. We should just be like, let's just do an EKG. Let's just see. You have a wire bra on? We need to take that off, girl. Here's a gown. So those can lead, though, to heart failure, MI, which is a heart attack, and sudden cardiac death. So your risk factors: tobacco use, hypertension, diabetes, and your cholesterol abnormalities. So your diet, right? So your LDL, that's the primary target for cholesterol lowering medications. So remember LDL, oh God, there was a thing about it. I think of LDL like a super villain. I had a name with it. It will come to me eventually. But that's where you give a lot of these different medications. You guys have just done pharmacology, so what's a cholesterol lowering agent?
Atorvastatin.
Yeah, torvastatin, right? The statins.
Yeah.
When do you take a statin?
Empty stomach.
What time of day do you take it?
Morning.
And then
Night. Cholesterol meds should be taken at night because that's when it's metabolized the most. That's like an instruction that they tell everyone, is to take your cholesterol meds at night. CRP, yeah, all that stuff. Okay, prevention of CAD. Tell me some stuff. How do I prevent coronary artery disease?
diet,
Yep,
exercise.
yep,
Stop
No
smoking.
drinking,
Yeah.
medication.
yep. Take your meds. Manage what?
Hypertension.
Hypertension. Remember, another one of the main four is diabetes. So diabetic patients are at higher risk for CAD. So, you know, if you have someone that comes in and they have uncontrolled diabetes, we need to start getting you on stuff, right? We need to start figuring it out. There's so many things now for diabetes too that can be given. I mean, you know, for some of our pre-diabetic patients and so on, they can put on metformin. Make sure you do your insulin doses. There's a medication. Maybe you guys have seen the commercial for it, Jardiance. Pee out sugar. Great. It's given for heart failure, actually. It's a part of GDMT to be started on that if you are pre-diabetic to diabetic. That's one of the meds that you get started on. That's SGLT2. Just to branch off there for pharmacology's sake, with Jardiance, it's also known as empagliflozin. What do you think is a risk factor for that med? That might be something like just you pee out sugar.
Hypoglycemia.
That could be one, yeah. But what do you think is a really big one? What do you think is something that like?
Kidney stones?
No. So okay, you take the med to pee out sugar. right, to help lower your sugar levels, but you're peeing it out. I am an older adult man, 70 years old, and I wear a diaper.
UTIs.
There you go. UTI. Because sugar is a breeding ground for what?
Bacteria.
And if you wear a diaper and you just don't get changed that often, or if you're incontinent, what do you think happens? Bacteria, bam, UTI, bam, sepsis, oh, people in the hospital. You know,
Can we take our break, Professor?
oh yeah, it's 9:45, go, 10 minute, 15 minute, come back at 10.